let's dive into a little bit of the Cabo and the lenvatinib data. So Nizar, let's take Cabo first. So the argument that one makes about cabozantinib, it's a potent VEGFR inhibitor, but also has the ability to modulate through inhibition of resistance pathways, AXL and MET. So there's a strong scientific rationale for why Cabo might be effective. Additionally, we have a press release on a trial called Cabozantinib, which suggests that even in the frontline setting, there may be a benefit for Cabo compared to sunitinib, although we'll not see the data for a bit of time until it's presented at an international meeting. So there's clearly scientific rationale for why Cabo might have a positive effect. So talk more about kind of the results of the trial, the toxicity profile, and how you think we should be thinking about this approach when patients come to us ready for second-line therapy.
So I think, we had, to talk about a little bit of the science, we had published in Oncogene last year around the time when the phase 3 data Meteor was presented at ESMO in Vienna, where patients, who had prior sunitinib, for example, we show that there is upregulation of these pathways, mechanism of resistance pathways that you mentioned, c-MET and AXL, and the drug cabozantinib particularly can show benefit when you give it post VEGF TKI. But as you mentioned, cabozantinib first-line therapy does also, there's no prior VEGF blockade. So I think, we know that tumors that are poor risk have higher expression of c-MET and AXL, and this a drug that blocks VEGFR and AXL and c-MET, I think, is doing something. So the reason cabozantinib is a unique TKI compared to the first generation of sunitinib, pazopanib, axitinib, is that it has that multi pathway inhibition. And I think finally, I think we would like to think that c-MET and AXL are important, although there is still, if you talk about biomarker analysis, we still do not know who are the patients who responded to cabozantinib. So it's not about just c-MET expression in a tumor from a nephrectomy specimen. So back to the phase 3 data of Meteor. I think, this is a large trial. It was a 658 patient trial in the salvage setting rather than second line setting. And the difference between it and the lenvatinib plus everolimus is that trial was a second line therapy trial, only one prior VEGF TKI, whereas Meteor allowed any number of prior TKI to be, although about 70% of the patients had only one. So it was a trial with a primary endpoint PFS, but it was powered enough to also address the OS, which was a secondary endpoint. And so also the presentation from last year and the New England Journal of Medicine publication that came out in September last year with the primary endpoint PFS being superior to everolimus. And 7.4 versus 3.8 months median PFS when comparing the two. And although the initial publication had a trend of improvement of overall survival, which was secondary endpoint, now we're going to hear on Sunday morning from Tony Shueria about the overall survival analysis. And there was a press release from the Meteor from Exelixis saying that the OS secondary endpoint was also met. It was powered and it did deliver. So here is an agent that, unlike the previous TKIs, delivers on objective response rate, PFS, and OS. So you have a trifecta, which is, I think, when you talk about two patients, they like to see that their tumors shrinking on CT and say, okay, so what Dan mentioned, cancer control. So, so I think this is a drug that's for real, and I think it's an added, tool or added agent to our armamentarium for our patients. So I think a lot of people say about the tolerability. Is this a tolerable agent? How you compare it to, say, nivolumab? And I think true, it does have adverse events like, the other TKIs. 60% of the patients on Cabo, on the Meteor trial receiving cabozantinib had to have dose reduction. And the median dose for patients ultimately was 44 milligram. But only 10% discontinued therapy because of toxicity. So I think it takes some learning, and I think if you have treated patients with sunitinib before and pazopanib, you know how to manage fatigue, diarrhea, hand-foot syndrome, etc. So I think in my opinion, as community oncologists have confidence in managing, embracing immunotherapy and managing, I think they'll be able to keep their patient on therapy for a long time and manage, as Dan mentioned, have your PharmD, your nurse in the clinic teaching those patients. And I think it's true. The first, month is the crucial months where education is important to be proactive, tell them how to manage, diarrhea with the anti-diarrheal medication, probiotic, etc. So I think that's the nutshell on the Meteor and the results. It's delivered on all 3 endpoints.